Welcome again in another discussion of treatment of drug sensitive tuberculosis. So in this discussion we will discuss and we will understand the treatment regime for the drug sensitive tuberculosis cases as per the current and latest guideline under NTEP. So let's start. So what are the learning objective today we have? Today we will to prescribe an appropriate antitubercular treatment regime based on location of the disease, smear positive and negative status of the patient, and we will also discuss a little bit about the tuberculosis and diabetes. It is called the double trouble because the both are problematic for the patient and they are called as double trouble. And we will learn ATD prescription as per the current national guidelines. What the current national guidelines today we are following, that we will also study and we will try to see what are the current antitubercular regime, various regime available for the patient. Okay. So before that, we should know how to prescribe an appropriate ATD regime. Actually, this is very important. This term, adjective term appropriate, is very important. Whenever we treat a tuberculosis patient, we must follow this 3R. Actually, this is the basic rule. Okay. So what are the 3R? Number 1 is right doses, that should be as per the weight of the patient. Number 2 is your right time, means all drugs should be taken at a right time, whether in the morning time or in the evening time, and right duration. Right duration means antitubercular treatment must be taken for a right duration as prescribed for 6 months, or for in some situation we prescribe 9 months, sometime in 12 months also, maybe extended duration also. That depends on the different clinical condition. So why it's very important? Actually, right doses. So important point is antitubercular treatment must be as per the weight of the patient. Underdosing and overdosing is not at all allowed. Okay, so weight band is fixed, and as per the weight of the patient we give antitubercular treatment, because underdosing will increase the chance of failure and also it will increase the chance of development of the drug resistant tuberculosis cases. So always we have to take the weight of the patient before prescribing any antitubercular treatment to them. This is very important for all of us to understand. And at the right time, what does it mean? It means that all drugs should be taken at the right time. Sometimes patients are not able to take all drugs in the morning time. For example, if somebody is doing an office work, office job, he is coming in the evening time. So for that patient, we can tell them that you can take all your medicine in the evening or night time also. But important point here is splitting is not allowed. We should not tell them that you can take one tablet in the morning, one tablet in the evening, one tablet in the night. That is big no. No splitting is allowed. All drugs, 3 drugs, 4 drugs, 5 drugs for that matter, must be taken at the right time. All drugs, either in the morning time or in the evening time. Okay. And it's a right duration. Right duration is very important. What happens whenever we start treatment for tuberculosis patient, they start feeling better in the 1 or 2 months of therapy. As the bacillary load, as the bacteria dies very rapidly in the first 2 months of treatment, and they feel better, they become clinically more or less okay, and they feel themselves that okay, I am cured from the disease, and what they do, they basically stop their treatment. And sometimes whether if they take also, they take very irregularly. Sometimes they will take for 1 day, they will stop for another 2-3 days or like that, so become irregular in their treatment. This is very important for them to understand. It's our duty to make them understand that yes, this medicine, you can be cured of your disease, but you have to take for right duration without any interruption. Daily means daily. So we have to strictly tell them that after 2 months, 3 months, whatever the duration is there for the treatment is decided by the treating clinician, that treatment duration must be followed. Patient should not stop the treatment, and they should not be irregular in their treatment. This is very important for all of us to understand. Okay. So that is how we should know that these 3 are while we are prescribing an appropriate antitubercular treatment. So we should also know the disease classification for which we are planning to treat a case. So how to classify the disease? First is from anatomical side. Anatomical side means where the disease is located. So it is classified in one is called pulmonary tuberculosis, that we call as any microbiological confirmed or clinically diagnosed a case of tuberculosis involving lung parenchyma or tracheobronchial tree. It's very important to understand that only it's a pulmonary parenchyma and tracheobronchial tree is involved here. Okay. Mediastinal structures, mediastinal lymph nodes are not involved here. That is in the another part called extrapulmonary tuberculosis. So in EPTB, any microbiologically confirmed or clinically diagnosed case of tuberculosis involving organs other than lungs like pleura, lymph nodes, intestine, genitourinary tract, okay, you have seen bone and joints and meninges of the brain. So here comes the lymph node. Mediastinal lymph nodes, they come as a extrapulmonary tuberculosis. Fine. And miliary TB, it is classified as a pulmonary TB because there is a lesion in the lungs also, because there is miliary mottling in the lungs, and so that is called as a pulmonary tuberculosis. What happens sometimes if a patient is having both pulmonary tuberculosis and extrapulmonary tuberculosis, in that situation it is classified, or it's called as a case of pulmonary tuberculosis, when the lesion are in the lungs and also elsewhere in the body. So in that situation we classify this patient as a case of pulmonary tuberculosis. All right. So another classification is here by your previous ATD treatment. If somebody was treated previously in the past, or by any means if somebody was prescribed antitubercular treatment in the past, so based on that situation we classify the case in, one is new case. A new case is what? A tuberculosis patient who has never had treatment for TB or has taken anti-TB drugs for less than 1 month. For example, many times a patient comes that he is treated some elsewhere by a physician and he was prescribed antitubercular treatment based on any clinical presentation, but he has taken for less than 1 month. Okay, so that will also be called as a new case. And another patient who has never received a antitubercular treatment, that will also categorize under new case. Okay, and previously treated patient are, they have received 1 month or more of anti-TB drugs in the past. Any patient who have been treated for antitubercular treatment for more than 1 month, they are all grouped together in a category, in a group called previously treated patients. Okay. And what are the recurrent TB cases? Recurrent TB cases is a TB patient previously declared as successfully treated, treatment outcome was cured or maybe treatment completed, and is subsequently found to be microbiologically confirmed TB case. So if that patient comes to us with the clinical sign symptoms and we do a smear examination, we found him to be microbiologically positive, so that case will be called as a recurrent tuberculosis case. So based on the classification of treatment, we decide to treat this patient under the following regime. That is, now if the case is new or a previously treated, so treatment regime in the IP means intensive phase, and treatment regime in the CP is a continuation phase. So in the intensive phase, 2 HRJD, that is 2 months of isoniazid, rifampicin, Z is for pyrazinamide, E for ethambutol, and the treatment in the continuation phase is 4 months of isoniazid, rifampicin, ethambutol. And it is the same in the previously treated case. So here we can see the regime remains the same for the both type of patient. So what is the difference? The difference is in the previously treated case, before prescribing them this regime that is similar to their new case, we have to always rule out MDR tuberculosis in this patient. We have to do a MDR or a monoresistant cases in category of previously treated cases before prescribing them this regime. So that remains a very important workup for this patient who are having previously treated. So we have to rule out them for MDR cases or for monoresistant cases, and if that investigation, that reports come us to be sensitive, then we have to give the same regimen that we are giving for the new patient. Okay. Now, so this is the drug sensitive TB as per National Tuberculosis Elimination Program under and also by the Indian Council of Medical Research. So what are the regime? Drugs are in the for IP 2-HRJD, as we have just seen, and in the continuous phase 4 months of HRA. Doses are 56 doses in your IP phase and 112 to 112 doses in the continuation phase. What are the doses? Doses are for isoniazid, that is 5 mg per kg per daily, range being 4 to 6 mg per kg. For rifampicin, the dose is 10 mg per kg per day and the range is your 8 to 12 mg per kg. For pyrazinamide, the dose is 25 mg per kg daily and the range is 20 to 30 mg per kg. For ethambutol, the dose is 15 mg per kg per day, range is your 12 to 18 mg per kg. For streptomycin, it is 15 mg per kg per day, range is 15 to 20. By now, we are not using injectable, and more or less injectables are used in very special circumstances when we do not have other option to use. Okay. So here we can see it's written streptomycin administered only in the certain situations like tubercular meningitis, or if first line drugs need to be replaced due to ADR or as per the weight of the patient. If the patient is not able to tolerate rifampicin, isoniazid, first line drugs, then if patient develops drug induced hepatitis, in that situation for a period that the liver gets better, we can use this is streptomycin, but nowadays injectables are best avoided. Okay. And these are the weight bands. Weight category, first weight band is 25 to 34 kg, second weight band is 35 to 49 kg, next is your 50 to 64 kg, and that is 65 to 75 kg, and last weight band is more than 75. Here we use FDC. FDC is called fixed dosage combination. What does it contain? Each tablet contains isoniazid 75 mg, rifampicin of 150 mg, pyrazinamide of 400 mg and ethambutol 275 mg. So 2 tablets, 3 tablets, 4 tablets, 5 tablets, 6 tablets in IP, and in the CP that remains the same. And in CP it is a 3 FDC, means 3 drugs are there. One is isoniazid, rifampicin and ethambutol. Pyrazinamide is not there in the continuation phase. So one drug contains all these 4 drugs and these are used as per the weight of the patient. Fine. So FDC, fixed dose combination, refers to the product containing 2 or more active ingredients in the fixed doses used for particular indications. Okay, so that is called fixed dose combination, means one tablet contains these 4 compounds: isoniazid, rifampicin, pyrazinamide and ethambutol, and 3 FDC contains 3 drugs, that is isoniazid, rifampicin and ethambutol. Alright. So in NTEP for adults, 4 FDC is given in IP, consists of HRZD, just we have discussed right now, and 3 FDC contains HRA, that is isoniazid, rifampicin, ethambutol. It is given in your continuation phase. This is a very important point for all of us to stress, and for we have to understand this one, because during treatment, if weight band of the patient increases by 5 kg and cross the next weight band, then the patient should be given the next higher weight band FDC. Okay. For example, what does it mean? For example, if at the start of treatment, if the patient weight was 30 kg and we have given him 2 tablets of 4 FDC in IP. After 1 month, if the patient becomes 38 kg, so will he be receiving 2 tablets? No, because he has gone to higher weight band, he has gained weight. So in that situation, we have to use 3 tablets now, because we know that we have to use the right doses for the patient as per the weight of the patient. So if the patient gains weight, for that matter, we have to switch him to another weight band as per his weight of the patient. Okay, this is very important for all of us to know. So here is the example of 4 FDC and this is a 3 FDC. So here you can see in the 4 FDC contains rifampicin, isoniazid, pyrazinamide and ethambutol, as we have just discussed now, and these are 3 FDC. This contains your rifampicin, isoniazid, ethambutol. So this is comes in the combination we are using. That comes in our mind that what is the role of pyridoxine in drug sensitive TB management. It's a very area of very confusion. Many physicians, even many clinicians are confused sometimes about, because of the lack of the information. Sometimes we have to use pyridoxine, we have not to use, in which situation we should use. So to make it very clear, the government has issued, our Minister of Health and Family Welfare has issued a letter dated on 22nd October 2021, clearly mentioning the use of pyridoxine among adult TB patient, drug sensitive patient under NTP, because for drug resistant cases the dose is different. So that we discuss in case of DRTB treatment. For the drug sensitive TB management, simply the dose is now 25 mg per day. It is not 10 mg per day. That is most common practice, 10 mg per day. That is not so. Dose is your 25 mg per day. Whom to give? All adult patient having drug sensitive tuberculosis. All adult patient having drug sensitive tuberculosis to be provided with pyridoxine 25 mg per day. What is the duration of the treatment? It's an entire treatment course. As long as the treatment is going for that tuberculosis, that they should be on your pyridoxine tablet 25 mg per day. Okay. And what is the rationale behind it? It has been found that it minimizes the risk of neurologic and psychiatric adverse event in these patients. So this is role of pyridoxine in your drug sensitive TB management. Coming to that discussion of little bit discussion about TB with comorbid illness. This is a very important topic for all of us to understand. There are many comorbid illness. Sometimes patient develops, or if the patient is having underlying problem, they develop tuberculosis. So that becomes a difficult to treat some situation. So here we will discuss 1 or 2 important comorbid illness, especially diabetic. So what is the treatment in that situation? Anti-tubercular treatment in appropriate weight band should be prescribed in patient with comorbid illness wherever possible. Means that 3 golden R that should be followed whenever we are treating any patient with comorbid illness. Okay, but sometimes ATD modification is required when a standard anti-tubercular treatment cannot be prescribed, like chronic kidney disease or chronic liver disease. Sometimes we have to modify the anti-tubercular treatment based on their renal profile and your liver profile, if they is having underlying chronic CKD or chronic liver disease. In that situation, we use the safe anti-TB drug as per the patient comorbid illness and their creatinine clearance or their LFT reports. And ATD doses are modified as per their liver and kidney profile that we do for them, for those kind of patient. This is very important for all us to know about the TB with comorbid illness, diabetes. Diabetes, we should know, we should discuss this thing, because it's a double trouble. Why it's called double trouble? Because diabetes have a very high risk for developing tubercular disease In that situation, we also give them on anti-standard anti-tubercular treatment, but strict control of blood sugar is must for effective TB treatment. This is very important to understand, because during the treatment of TB, if blood sugars are not controlled, then treatment will not be effective, and the chances of failure are very high in such cases. In 2021, CDC developed a TB surveillance report, and in those, what they have found, that this is a very alarming observation they made, that 1 in the 4 people with tuberculosis also has diabetes. So out of 4, 1 will have a diabetes. Okay, so this is very important observation they found in the surveillance the CDC observed. And what happens in diabetes? Actually, in diabetes there is a altered immunity. We know that diabetes is a status of immunosuppression sometimes and a poor immunity. So in that situation, if the latent tuberculosis, the chances of developing into active is very high. Here we can see latent focus is there, that gets activated, okay, and cause active tuberculosis. In that patient also, relapse is very high, and the risk of death is also high in diabetic patient. So because of this, this is called as a double trouble. It's very important for all of us to understand and address the situation. Okay, and tuberculosis itself predisposed to hyperglycemia. The patient having tuberculosis have a hyperglycemic state, because studies suggest that the TB can even cause diabetes in those not previously known to be diabetes. It's very important to know, means tuberculosis itself, it's a pro-diabetic factor. So it can cause diabetes even those not previously known to be diabetic. How does it do it? Because following mechanism: number 1 is cause decreased hepatic glycogenesis. It can because of the increased hepatic glycogenolysis and gluconeogenesis. There is a lack of insulin due to impairment of pancreatic islets cells, and tubercular bacilli suppress the sensitivity of tissue to the insulin. So by doing this, they increase insulin resistance, and further that will contribute to development of your diabetes. Okay, tuberculosis itself causes tissue destruction, and that helps to development of diabetic. And we know that this INH, isoniazid drug, that is used in the management of tuberculosis, drugs and tuberculosis, have a diabetogenic effect. So this is very important, that tuberculosis can predispose to hyperglycemia or a frank diabetic also. So what is the outcome for that? Effect of tuberculosis on diabetes. So what does tuberculosis does on diabetes? It causes worsening of your diabetes state, and tuberculosis might induce glucose intolerance and worsen glycemic control with increased insulin requirement and ketosis. And the endocrine function of the pancreas has also been found to be adversely affected in severe tuberculosis, and a higher incidence of chronic calcific pancreatitis occur in patients with concomitant diabetes and tuberculosis, leading to an absolute or relative insulin deficiency states. So during the treatment of tuberculosis, the patient sometimes develops some sort of pancreatitis, and that becomes later on there is a high risk for developing chronic calcific pancreatitis, and that will cause your almost absolute or relative insulin deficiency. And for a diabetic, or if they are diabetic, they have a very poor diabetic control, they have more insulin requirement, and they have more adverse outcome for the diabetic per se itself, because of the damage to the pancreas in that matter. Okay, and now what happens? Effect of diabetes on treatment outcome of TB if the patient is a diabetic. So how does this affect on the treatment part? Diabetes is associated with possibly delay in the sputum culture conversion. Patient has a very delayed conversion sometime, and there is an increased risk of death, and there is an increased risk of recurrent TB in these patients. So because of all these factors, it is very important for all of us to have a strict blood control of blood sugar is must for effective TB treatment. So during the course of treatment, and even before that and after that also, the diabetic patient must have their sugars properly and strictly controlled for the treatment to be effective. So this is for all today. Thank you so much for watching, and if you like this video, like, comment, share and subscribe the channel for the further updates. See you all in the next video. Thank you.